Hello, my name is Ash Acharya. I'm a consultant orthopedic surgeon specializing in hip and knee surgery at Warrington Hospital and Spire Cheshire Hospital. Today, I would like to talk to you about patellar dislocation, also commonly known as kneecap dislocation. It is a common condition in second decade of life or occasionally third decade of life, and it is commoner in women. How do you tell if somebody has patellar dislocation? Usually, the patient will remember significant injury. It can be a twisting injury such as dancing or contact sports related injury or jumping. The patient will have quite significant pain and swelling. The knee will be a bit bent and the kneecap will be sitting on the side of thigh bone. The patient will probably require gas and air or pain relief. What stops the kneecap coming out normally? Normally, there is a groove at the end of the thigh bone where it reaches the knee. This special groove, the shape of kneecap and surrounding soft tissue balance keeps the kneecap in place. The kneecap works as a system of pulley and lever and guides in this groove normally. With injury, the soft tissues around the kneecap can get damaged and then the kneecap comes out of the groove. What treatment is needed for patellar dislocation? In the first instance, we reduce the kneecap. It can be done very easily and effectively by just gently straightening the knee and putting slight pressure on the outer border of patella. However, if significant time has passed since injury, the patient may require pain relief and gas and air, or occasionally bit more in terms of sedation. After the dislocation is reduced, the patient is provided with a splint and crutches. Once you are comfortable, it is better to gradually wean off the brace by latest 2 to 3 weeks. You will need physiotherapy. You can take full weight on the leg. However, before considering this, we will need to see you in the clinic, ensure that there is no further bony injury. So what treatment do I need after the first dislocation, and do I need surgery? Well, the good news is that after first dislocation, majority of the patient recover very well and don't need further surgery. We will assess you in the clinic and I will look at your radiographs and look at your profile. If a patient has a shallow groove, if the patient has ligament laxity or high riding patella, in these cases, further dislocation is a bit commoner. However, if there are 100 patients in a room with patellar dislocation, 85 may not have further dislocation. So the chances of further dislocation are very remote. So which patients require surgery after first dislocation? We evaluate the patient and get x-rays. If there is a loose flake of bone or loose flake of cartilage in the knee, the patient may require keyhole surgery of the knee to remove it or to fix it. Whilst you are performing this procedure, I will also repair the soft tissues around the knee. If the patient has 2 dislocations or more, then it is far more likely that the patient will have third dislocation. The chances are more than 50%. So I will need to assess the patient, take a history, examine the patient, and arrange MRI scan. The surgery is to recreate the soft tissues on the inside of the knee. It is called as MPFL reconstruction. I will then probably combine this surgery with another surgery if required, such as tibial tubercle osteotomy if a patient has high patella. During the MPFL reconstruction, we take a small piece of hamstring tendon and then fix it to the inside of the patella and connect it to the inside of the thigh bone. This creates an elastic band on the inside of the patella and stops it come out. What are the risks and complications of the operation? Well, the risk and the complication of this operation is similar to keyhole surgery. There is also a small risk of further pain or discomfort and stiffness of the knee. There is also a small chance of damage to nerve or vessel Occasionally, patients have some numbness on the inside of the knee. The scar on the inside of the knee also can be sometimes sensitive. What is the recovery after the operation? The patient will need brace for about 6 weeks and may need crutches between 3 to 6 weeks. You will need removal of clips or stitches in 2 weeks after the operation. You are allowed to walk taking full weight on the leg. The brace will be adjusted over a period of 6 weeks. You will be able to bend the knee. After 6 weeks, the brace is discarded. You may not be able to drive for first 6 weeks. You may not be able to go on air travel for about 3 months after the operation. You can return to sedentary work after 6 weeks or so. If your work is fairly manual, then you may need up to 3 months off work. By 4 weeks, you can start walking longer distance. By 4 months, you can start jogging. You should avoid contact sports for 9 to 12 months. It is fairly successful operation. However, initially, you will need to be committed to physiotherapy.